The objectives for this presentation are to review neuroplasticity and motor learning, to compare and contrast high-intensity gait training to conventional physical therapy, to learn the neuroplastic principles behind high-intensity gait training, and to examine its effect on orthotic management. If you're used to observing conventional physical therapy interventions for stroke patients, it can be surprisingly different when you come across high-intensity gait training for the first time. Why is this? The primary focus is walking, and you will see patients up and walking no matter the severity of their stroke, their age, or body size. You will see patients walking over ground, on treadmills, and some with harnesses and maximum body weight support. Because it is so different from conventional therapy interventions, as orthotists, we need to look at these patients differently. Here are some of the key points that I have learned while working with patients that receive this type of therapy. First, maximize independence, not perfect kinematics. In therapy, there's a focus on optimizing gait speed and distance walked, as these are statistically significant factors that impact quality of life. As a result, perfecting kinematics takes a backseat role. Second, amount and speed of motor return and planning. Because therapists are focusing on just one task and are utilizing principles of neuroplasticity during this prime window of neuroplasticity post-stroke, patients are able to achieve greater amounts of motor recovery and planning. And lastly, collaboration between physical therapy and orthotics. Physical therapy cannot do what they need to do for this therapy without us. And we need to understand what, how, and why physical therapists implement high-intensity gait training so that we can best formulate our orthotic treatment plans. So now I'll turn it over to my colleague Caitlin, who will jump into the rationale and evidence behind this modality.
In order to understand what physical therapists do in the clinic, we need to first understand the concept of neuroplasticity. The brain was once thought to be static, but new studies have shown that the brain continues to change throughout the adult life. This ability to change, this mechanism of encoding experience and learning new behaviors, is known as neuroplasticity. Many of the interventions that physical therapists provide in the clinic are structured to promote neuroplasticity in our patients and thus facilitate functional recovery. In 2008, Klein and Jones published an article that described 10 principles of neuroplasticity, or in other words, 10 ways in which we can influence change in the brain to promote new behaviors. While all of these principles are important to consider, I really want to highlight 3 of them. Specificity, meaning that the nature of the training experience dictates the nature of the plasticity. Repetition, meaning that induction of plasticity requires sufficient repetition. And intensity, meaning that induction of plasticity requires sufficient training intensity. These 3 principles of neuroplasticity are pervasive in PT practice at the Shirley Ryan Ability Lab. To highlight the extent of repetition and task-specific practice that's required to facilitate neuroplastic change, various studies have been conducted that mapped the motor representation in the brain before and after repetitive task-specific training. And as you can see here in both the upper extremity and the lower extremity, thousands of repetitions are required during motor skill acquisition to facilitate the increased dendritic growth, synaptic strength, and neuronal activity that is necessary to produce long-lasting alterations in motor performance. Despite such findings in the previously mentioned studies, the amount and intensity of traditional PT practice observed during inpatient rehab of individuals post-stroke is limited. An observational study by Lang et al. In 2009 found that patients in the inpatient setting practiced a variety of walking and non-walking tasks during therapy, but limited amounts of practice of any single behavior, nowhere near the amount needed to facilitate neuroplastic change. Instead of this conventional structure of therapy, therapists should be prioritizing their treatment sessions to achieve high repetition of functional tasks at high intensities. Therapists need to be implementing high-intensity gait training with their appropriate patients. It's an extremely functional task that allows for substantial repetition to facilitate neuroplastic change and thus achieve improved functional recovery. So here's a side-by-side comparison of conventional PT to high-intensity gait training. Looking at conventional physical therapy, therapists will maintain an overarching goal of incrementally challenging patients above their current functional practice, adapting the thought process of, well, once the patient can stand safely, then we'll practice walking. And then once the patient can walk safely, then we'll practice stairs. And with that, conventional therapists integrate a lot of non-locomotor tasks, seeing these as building blocks to allow progression to walking activities. Then, when patients are ready for walking, therapists divide walking into practice of pre-gait activities such as weight shifting and stepping forwards and backwards in the parallel bars, before progressing to whole practice walking with an emphasis on normalizing gait patterns and avoiding abnormal spastic motor behaviors. The cardiovascular intensity and repetition of tasks throughout conventional PT sessions has been documented to be relatively low and nowhere near the amount required to facilitate optimal neuroplastic change as identified by research. Now, in contrast, therapists that are implementing high-intensity gait training prioritize the goal of whole practice continuous upright stepping training. Therapists emphasize achieving a cardiovascular intensity of 70 to 85% of the patient's target heart rate max, which will be discussed later, and high repetition of steps per session. There is minimal focus on normalizing gait patterns and instead on maximizing function as defined by walking speed, distance, and assist level. Walking practice in variable contexts is also integrated into training as soon as able based on the degree of skill acquisition. So you can see that there's a substantial difference between conventional PT sessions and those conducted by therapists prioritizing high-intensity gait training. Yet many of you might be wondering how are patients improved in other functional tasks required for daily living, such as bed mobility, transfers, and standing balance, if therapists are spending so much of their time on high-intensity gait training. And this is a valid question, and by no means do I want to convey that therapists ignore these other functional tasks. However, recent research has shown that by practicing a higher level task, like walking, the patient not only achieves gains in walking, but also achieves gains in lower level tasks, like transfers and balance. This is what's called the reverse transfer of skills. And this concept allows PTs to ensure appropriate dosing of high-intensity gait training without taking away from potential improvements in those lower-level tasks. The theory behind this is that during high-intensity gait training, the demands of the axial and lower extremity musculature to maintain upright posture and frontal and sagittal plane stability are substantially increased. This level of activity may elicit long-term changes in neuromuscular activation patterns and improved postural control, which then translates to improved performance in those lower level tasks. In order to achieve such substantial gains, though, therapists need to select interventions that are intensive, repetitive, and task specific. All right, so let's review review those principles of neuroplasticity that are particularly important when implementing high-intensity gait training. First, task specificity matters. As previously mentioned, gait training for patients post-stroke was traditionally divided into parts, or pre-gait activities. But there is no evidence that pre-gait tasks actually translate into improved walking. Rather, therapists need to be practicing gait as a whole task, which is functional, task-specific, and simultaneously addresses balance, weight-bearing, and stepping. And if patients are unable to engage in overground walking practice for whatever reason, whether that's weight, severity of deficits, or their cognition, then therapists should still prioritize whole practice walking via other means, like the treadmill, to get the stepping repetitions needed to facilitate neural. And in 2010, Moore et al. Sought to directly test the contribution of total amount of walking practice to improved walking performance. She conducted a randomized crossover clinical trial in which all participants, who were 6 months post-stroke with moderate to severe walking impairments, received 4 weeks of outpatient PT and then either received 4 weeks of locomotor training immediately following outpatient PT or 4 weeks of locomotor training following a 4-week delay after discharge from outpatient PT. Clinical measures were assessed prior to and following discharge from PT, prior to and following intensive locomotor training, and prior to and following the delay period. Additionally, stepping activity performed in the home, community, and in PT sessions was recorded on a step counter to provide an estimate of stepping dosage throughout the day and during locomotor training sessions. During the course of the study, the step counter revealed that the average stepping dosage was 900 steps per session in outpatient PT compared to 4,000 steps per session in the locomotor training protocol. This is a huge difference. And upon further statistical analysis, the researchers found that the number of steps per session was significantly correlated to the change in daily physical activity. There was a 25% increase in total daily stepping within the home and community following 4 weeks of locomotor training, in addition to the significant improvements that were noted in walking speed, time distance, and gait efficiency. So the results of the study suggest that the amount of practice or task-specific repetition performed during training may contribute to considerable improvements in community ambulation, and thus bring patients closer to their prior level of functioning, which is the ultimate goal for any therapist. And then there's intensity, which we define as work per unit time, or power or workload. Just as force and velocity impact power in physics, they also impact the workload or cardiovascular demands for the patient. Therefore, by manipulating speed and force, therapists can affect the intensity of treatment sessions. So the concept of manipulating speed to impact intensity is self-explanatory, but some of the commonly used methods to manipulate force include adding ankle weights or a weighted vest, increasing incline, applying resistance to the patient's limbs or pelvis, decreasing upper extremity support, etc., etc. There are a variety of ways to manipulate intensity in a manner that also addresses the patient's gait impairments. And we'll touch on this a little bit more later on. Now, it's important to note that therapists are monitoring the cardiovascular intensity of their sessions to ensure patient safety, as well as adequate intensity levels to facilitate neuroplasticity as defined by the literature. The majority of studies recommend a cardiovascular intensity of either 70 to 80% of the patient's heart rate reserve or 70 to 85% of their heart rate max via the Tanaka formula. And more often than not, therapists will be monitoring intensity levels via heart rate max. Therapists are also monitoring intensity in a variety of other ways, including blood pressure, abnormal cardiovascular symptoms, and the patient's perceived exertion level via the Borg's Rate of Perceived Exertion Scale, or RPE scale. This is a 6 to 20 point scale that allows clinicians to track exertion levels, 6 meaning no exertion at all, and 20 meaning maximal exertion. Literature has defined high intensity as an RPE between 14 to 17, or hard to very hard. So I keep going on and on about intensity, but why does intensity matter so much? Increased intensity positively impacts each of these areas on screen: cardiovascular function, neural recovery, and walking outcomes. Improvements in any one of these areas positively impacts the others. When training at increased treadmill speed with increased neuromuscular activity, our bodies respond with increased cardiovascular activity to meet the metabolic demands. This increase in cardiovascular activity results in the release of neurotrophic growth factors and neurotransmitters that facilitate plasticity. Brain-derived neurotrophic factor, or BDNF, is one of these crucial mediators of plasticity. It demonstrates a remarkable activity-dependent regulation of expression and secretion, meaning that the harder you're working, the more BDNF that is released. The increase in neural activity via volitional command, coupled with the upregulation of neuromodulators during high-intensity training, has been shown to facilitate plastic changes in the nervous system and expedite recovery following a neurological injury. In other words, high-intensity aerobic training primes the brain for recovery by releasing growth factors like BDNF and neurotransmitters that facilitate plasticity. Alright, so even though we want adequate repetition and intensity to solidify neuroplastic changes, it's also important to introduce variability during locomotor training to simulate real-world situations that our patients must face outside of the PT session. Variability matters. Studies have shown that patients demonstrate better retention in motor learning with variable practice rather than forward stepping alone. It was also found that errorless practice does not promote learning. Fortunately, introducing variability into locomotor training also increases intensity. Some of the ways that clinicians integrate variability include multidirectional stepping, obstacle negotiation, dual task training, really any of the things that a patient may encounter outside of the controlled hospital environment. So by introducing variable context into gait training, it's expected that patients will experience errors as they explore and learn different movement solutions to accomplish tasks. This trial and error practice provides error feedback, which is an important component of motor learning. The cerebellum plays an essential role in storing a set of parameters called an internal model. Error feedback can update the internal model until the movement error is reduced. And once these new parameters are recalibrated, after effects may be exhibited if the new demand is removed. For example, if a patient is engaging in forward stepping and demonstrates extreme circumduction during swing phase, a therapist may choose to apply a TheraBand to the patient's impaired limb and pull laterally to further augment the circumduction and force a larger error. In order to continue walking successfully, the patient has to increase drive in their adductors or hip flexors. After a sustained period of time, the therapist then releases the TheraBand with the hope that the after effects are exhibited and the patient demonstrates more functional kinematics for swing phase due to the increased drive in the adductors or hip flexors. This new movement pattern is then reinforced with cues from the therapist over multiple sessions to create sustained improvements. Now, of note, therapists are implementing variable context strategically and constantly assessing the patient's success to error ratio. Therapists need to ensure that patients don't lose motivation due to excessive failure during tasks and also need to ensure sufficient repetition to induce neuroplastic change. If the patient is consistently failing at a particular task, then the therapist would need to modify the intervention to ensure the just right challenge is achieved. This graph depicts the thought process behind introduction of variability and error augmentation. As patients start to learn a new skill like walking, they'll be on the far left of this graph. A high level of assistance is required in this stage of learning to ensure task completion and achieve sufficient repetition. As they start to acquire the skill and less assistance is required from the therapist to achieve success, errors in variable task training should gradually be introduced and then rapidly increased as the patient starts to master the skill. To give an example, think of your classic stroke patient that demonstrates poor toe clearance. When the patient first admits to inpatient rehab and is at the far left side of this graph, the patient may require manual assistance from the therapist to complete swing phase. As the patient progresses in therapy and is able to complete swing phase with only occasional assistance, the therapist may initiate error augmentation by adding a small ankle weight. Once the patient successfully and consistently completes swing phase with this, the therapist will introduce additional tasks to challenge toe clearance, such as heavier ankle weights, inclines, or obstacles to step over. And by ramping up the challenge appropriately and forcing continual adaptation, we can ensure that the patient progresses toward a higher degree of skill acquisition and thus functional independence. It is important to note, though, that variable tasks and locomotor training in general should only be practiced with assistance as needed to ensure task completion, which we define as continuous reciprocal stepping in a specific direction with non-negative step length and plantar surface contact without limb collapse during loading. Therapists should not be providing additional assistance to perfect kinematics during gait training. Many training protocols have focused on consistent, symmetrical, kinematically correct stepping patterns during gait training that minimize kinematic errors and variability. However, locomotor kinematics may not change substantially. Both animal and human studies have shown that kinematically constrained treadmill stepping can limit improvements in gait symmetry and joint kinematics, particularly as compared to strategies that allow kinematic variability. In fact, improved joint kinematics were noted in the groups that allowed kinematic variability and were not practicing perfect. So while incorporating training that challenges a variety of locomotor tasks at high intensities can elicit substantial errors in task performance, locomotor performance, including gait kinematics, may improve over the long term if patients can adjust their locomotor strategies to correct these errors. In 2014, Halloran et al. Found that 4+ weeks of high-intensity locomotor training in variable contexts resulted in significant locomotor improvements, including self-selected gait speed, fast gait speed, paretic limb stance time, and time distance walked as measured by the 6-minute walk test. Now, as John mentioned at the beginning of this presentation, the goal of high-intensity gait training is to maximize functional independence in our patients and get them as close as possible to their prior level of function. The goal is not to perfect kinematics. We care more about improvements in gait speed and time distance walked since they're directly correlated to quality of life as well as home and community walking behavior. However, in order to optimize functional gains for our patients, physical therapists need the help of an orthotist. They need a custom brace that appropriately fosters safety and also the functionality required to engage in high-intensity gait training during PT sessions. So with that, I'd like to turn it back over to John to further expand on the importance of the collaboration between orthotists and physical therapists.
So we need to understand what is different between what physical therapists focus on and what orthotists usually focus on when it comes to gait. Because in our field, orthotics and prosthetics, we typically want to create perfect. We all learn in school about Perry's 5 stance phases of gait and 3 swing. When we look at prosthetic patients and their gait, we can perfect it with set screws, outsetting of the foot, and making particular changes. We really need to throw this way of thinking out of the window when it comes to this modality, this therapy. So successful gait is not perfect step. What it is assistance as needed for task completion, gradually reducing acceleration. So what is task completion? Caitlin talked about task completion in the lower extremity, and that is the continuous reciprocal stepping in a specific direction, non-negative step length, plantar surface contact without limb collapse during loading. So I will now go over the 4 biomechanical subcomponents of gait that physical therapists focus on to ensure task completion. The first is limb advancement, and that's the ability to advance a swing limb. And this could be the physical therapist advancing it. It could be using body weight support to help advance it. The second is stance control, and that's the ability to prevent the limb or the trunk from collapsing when walking. Again, this can be achieved through the help of body weight support, or the physical therapist could be blocking the knee. The third is propulsion, and this is the ability to move the body forward. Again, this can be assisted through pelvic straps. It could be assisted through the physical therapist pulling on the walker when the patient is walking over ground. And lastly, stability and balance. This means maintaining balance, maintaining step width, having proper inversion at the ankle, hip strength, weight shift. All of this may be facilitated or helped by strapping the harness or the physical therapist. So now I want to give you an overview of where this high-intensity gait training is done at the Shirley Ryan and Building Lab. Primarily done in the Legs and Walking Lab, which is up in the 23rd and 24th floors of the building. This lab is staffed by physical therapists, occupational therapists, speech, researchers, and gait specialists. The Legs and Walking Lab has 2 floors with 8 treadmills that have body weight support systems. Each floor of the Legs and Walking Lab has an overground track with an overhead harnessing system and 2 sets of parallel bars. The Legs and Walking Lab has 2 sets of stairs. One of these connects the 2 floors and has a harness system for body weight support and safety. The second set of stairs is more traditional in design, has 4 steps up and down. The Legs and Walking Lab is also the home of a daily orthotic evaluation clinic that offers collaboration between physical therapists and orthotists in assessing for lower extremity orthotics. This slide shows the equipment setup for the body weight support, treadmills, and harnesses in the Legs and Walking Lab. You can see how the body weight support harness is down on the patient, then attached to the treadmill via the carabiners in the photo. Below it, you can see the pelvic straps that are used, both posterior and anterior, sometimes lateral straps. To the right is the heart rate monitor that monitors. This setup allows patients to practice stepping This slide demonstrates the overhead track and harness system in the legs and walking lab. This system allows patients to safely ambulate over ground with either zero or minimal body weight support to full maximal body weight support. This case study is on Chris, a 34-year-old stroke patient who had a stroke in the end of April of last year. He was seen in Shirley Ryan Ability Lab at the beginning of May. You can see him on the treadmill now. He's using a posterior leaf spring and off-the-shelf AFO, and the therapist needs to help him advance his leg and swing to position, and he also presents with some hyperextension of the knee and some corona instability at the ankle. The same session, he receives a solid AFO, a custom solid AFO, and you can see now that he's advancing his leg on his own. The therapist does not have to help position his leg. And he also has more control coronally and of knee hyperextension. So his heart rate is 110 with the posterior leaf spring AFO, but with the solid AFO, it's 138. So the intensity is increased because he's now positioning his leg on his own and is not requiring as much therapist assistance, which is another benefit of having a properly fitting and custom AFO. So now we see him on 528, walking over ground. And he's using the left quad cane for stability and balance. He has no body weight support. Again, he's using his custom solid AFO. So the first challenge is to take away the cane and to add an ankle weight. And what this does is increases the ear augmentation for right swing phase. And now you can see that he's holding the therapist's hands and he's working on increasing propulsion, which also affects his speed and increases intensity. And now he's working on variability. He's walking sideways. He's working on his hip abductors and adductors, working on different muscle groups. So walking backward, forwards, sideways, all of this is better than walking only forwards. So this session is 2 days later, and he's working on stairs and the treadmill. And stairs, again, is variable context, so it helps with variability. And it also helps with intensity doing stairs. And the subcomponents of gait that are worked on are propulsion and limb advancement, as well as home and community mobility. This is the same session. He's on the treadmill doing the foam block challenge. So these principles are variability and ear augmentation. In having the foam block challenge, this intensity really increases his heart rate to 155. The target range for him is 129 to 157. So we're right at the top end of the target range. Now, this challenge is taking his hands off of the treadmill, off of the side rails. He's still safe with the harness. And this works on balance. And he's also working on limb advancement as well as air augmentation. So in this next view, you see Chris walking at a self-selected speed, no body weight support, and you can see how his speed is just so much faster than it was 8 days earlier. You can see the therapist is advancing and using the posterior leaf spring AFO. So this is how much high intensity really accelerates motor return. We'll now talk about high intensity gait training's effect on orthotic management. First, use AFOs. The 2008 evidence note from AOPA is a key point that AFOs should be considered in stroke management and individually fit by a certified orthotist. A systemic review done by Lang and Mosley in 2002 concludes that AFOs may improve velocity, stride length, gait pattern, and walking for people with hemiplegia. Other studies have shown articulated AFOs with plantar flexion stops improve early stance phase knee moments, reduce hyperextension, and improve foot placement. AFOs can have meaningful and immediate impact on the velocity and cadence of acute hemiplegic stroke patients. And AFOs may influence balance by improving balance confidence through self-efficacy, which is particularly important in the fall-prone post-stroke population. Self-efficacy is the belief in one's abilities to succeed in particular situations and is strongly associated with activity and participation. Use AFOs now and make sure that they are custom AFOs. AFOs are needed at the beginning of this modality. Due to the focus on stepping and thousands of repetitions involved, AFOs are needed for proper foot placement and ankle and knee control. Custom polymer AFOs offer greater coronal control of the foot-ankle complex than off-the-shelf prefabricated AFOs. Custom AFOs made from a good impression and well-modified cast are the best way to avoid skin breakdown and pressure that can occur from thousands of steps in one therapy session as opposed to an ill-fitting trial AFO from the donations bin or an off-the-shelf AFO. Hospitals are now being penalized financially for hospital-acquired skin breakdown, so there is a new focus and awareness of avoiding skin breakdown. AFOs also reduce the therapist's involvement in safely guiding steps. This is important because when a patient steps on their own, there is an increase in intensity, ears, muscle activation, and neuromuscular feedback. It is important to follow up regularly and to ask the treating therapist to check and monitor patient's skin. Remember, patient's gait can change rapidly with this type of therapy, so even though you may have textbook clearance at the malleoli, this may not be enough when they begin walking over ground in variable context with induced errors. Keep adjustability of the AFO in mind. If we keep with our last point that sooner is better than later, and we provide an AFO at the beginning of high-intensity gait training, then we need to understand that the AFO that a patient needs today may not be the one that they will need 3 months from now, or even 3 weeks from now. Because we can't provide a new AFO every few weeks, we need to build adjustability into our mindset and into our AFOs. The amount of motor return and planning is greater and faster with this modality. Patient's prognosis should be discussed with clinical team. Remember, age, stroke type and location, past strokes, current function, and walking speed matter. When anticipated rate of motor return is slower, solid AFO design should be considered as they can be adjusted more gradually from solid to rigid to semi-rigid to flexible. Pre-articulated AFOs or an ability AFO can be used for when faster rate of return is anticipated, or when patients may need prolonged control coronally at the ankle or for hyperextension at the knee. Consider newer stance control AFOs such as the Becker triple action joint AFO and Fiora and Gentz's neural swing AFO. Both of these are custom AFOs with highly adjustable ankle joints in terms of range of motion and stiffness that make it possible to easily react to improvements in gait. Next, we will talk about the effect on orthotic evaluation. If possible, have the patient ambulate over ground to get an idea of their function. If they are walking on the treadmill with bodyweight support, then get an understanding of how much bodyweight support is being provided and why. Is it due to weakness? Is it to allow for improved stepping to get the number of repetitions needed? Don't be afraid to ask to reduce bodyweight support to see how this changes their gait. Does the patient really walk this bad? The physical therapist may be incorporating air augmentation. One tip to remember is that arrow augmentation is increasingly used once a patient acquires a skill of walking, unless assistance is needed from the therapist to achieve success. A 2019 study found substantial gains in locomotor speeds following high-intensity stepping training provided to patients post-stroke, resulted in changes in movement strategies that reflect both improved neuromuscular recovery and increased compensation. Behaviors such as hip hiking and circumduction were utilized. So patients may need both recovery and compensation to achieve gains in walking function. Don't discount patients who cannot stand or step independently. Even if they end up not being functional ambulators, remember the concept of reverse transfer. Stepping activity is significantly related to improvements in non-walking activities such as balance, bed mobility, and transfers. And no KFOs. You do not want nor need a locked knee joint for this training, nor the bulk and weight that comes with a KFO. If you're at this point in the presentation and you're wondering why any of this should matter to you, here are a few more reasons. 795,000 Americans have a stroke each year. Stroke is a leading cause of serious disability in this work and results in reduced mobility in more than half the survivors aged 65 and older. Number two, this is the way that physical therapists are beginning to treat stroke patients and are only going to do so in greater numbers as the American Physical Therapy Association released a new clinical practice guideline in January of this year that strongly recommends the use of high-intensity gait training to improve locomotor function following chronic stroke, incomplete spinal cord injury, and brain injury. Clinical practice guidelines inform not only clinicians, but patients, the public, and payers. Number three, walking speed is the sixth vital sign. It reflects both functional and physiological changes. Self-selected walking speed is a reliable, valid, sensitive, and specific measure that correlates with functional ability and balance confidence. A 2019 study found 110 subacute stroke patients in Sweden, half of them receiving high-intensity gait training and half conventional therapy. They used a walking speed of 0.93 meters per second as a value associated with full community mobility. At the conclusion of inpatient rehab, 58% of high-intensity gait patients achieved full community mobility, while only 26% of conventional therapy patients did. And lastly, be the expert. Differentiate yourself from the other O&P clinicians and practices. Partner with your local rehabilitation hospital or stroke unit to observe and learn this modality if they have already implemented it, and introduce it to them if they have not. Collaborate with your go-to physical therapist to read up on the high-intensity gait training literature and consider taking a course together. This will improve the outcomes of your shared patients while differentiating yourself from the competition. If you are interested in learning more about high-intensity gait training, the Academy and Shirley Ryan Ability Lab offers an annual stroke course. This course typically has a workshop on high-intensity gait training as part of its curriculum. This year's stroke course is completely online and is at the beginning of May. You can also refer to our reference section, which has the scientific literature. Thank you for joining us, and thank you to ISPO and Marlo Ortiz for the opportunity to present our work today.
Great, thank you. Thanks to both of you for the presentation. I'll invite anybody that has questions now. We've got about 10 minutes or so, 10 or 15 minutes for questions. You can just write them in the chat. And hi there. So the first question, there was one question on the chat, I'll just read it out. Do you include in the initial evaluation or during the training the overall alignment and muscle balance of the patient? And if so, how do you include this information? Oh, sorry, you can,
To try to answer the question, when we do the evaluation, we do check the manual muscle strength and range of motion to get an idea of the alignment, if we need to post, if there's a contracture in that side. And then we also look at the manual muscles and see what strength we have, but we also look at the patient when they're walking and see if they have functional strength that doesn't show up in the manual muscle test. So we're looking at them functionally but also the manual muscle test as well, and taking that into consideration in terms of how solid or how flexible we need to make the AFO.
I've got a couple questions. It's quite interesting. How long would you take a patient through this process? I imagine it starts when they're an inpatient and they stay as an inpatient, or do you treat them as outpatients as well?
Specifically for physical therapy, you know, we will administer this intervention of high intensity gait training in the inpatient setting, but it's also the expectation to continue this intervention at the next level of care as well. So either in a day rehab setting or an outpatient setting, as the patient continues to gain independence with their functional mobility. The interventions that we're providing or the impairments that we're specifically addressing will obviously change as the patient improves, but we do expect that it's not only an intervention that's administered on inpatient, but in day rehab and outpatient as well. And that is something that our national organization has just recently reinforced with a clinical practice guideline that outlined the importance of high intensity gait training for stroke patients and other patients with neurologic diagnoses across the continuum of care.
Another question from the chat. Is it important for the height of the heel of the shoe for correct design of the AFO?
Yes, we do take that into consideration to see if it's a neutral heel or if there's elevation to the heel. But I would say that most times we do align the AFO and then the patient has to get a larger shoe. So we try to give the idea to the patient of what type of heel they should have or what type of shoe as well to work with that AFO alignment.
Thank you. I was interested too that you use magnifying errors of the patient to improve walking performance. It seems opposite from what we're trying to always get people to do the right movements, but I think it's quite fascinating to think that you can magnify their errors and you improve. They end up improving. How did that come about? That idea, you know?
Well, I think the idea came about, just in terms of general physiology, right? We continually challenge our bodies to improve. And so with error augmentation, knowing that that is a component that the cerebellum focuses on and that our bodies can adapt to errors and fix those errors and improve, we really applied that to our own intervention. So, we're not just looking to do a perfect kinematic gait pattern. In fact, the research has shown that kinematically constrained gait training can actually be detrimental to showing improved joint kinematics after the intervention is performed. So for instance, that study is coming from a research study where the patients were performing gait training with robotic assisted therapy, so perfect kinematics. And what they found is those patients actually didn't improve in their joint kinematics as much as the patients who were allowed a little bit more kinematic variability when they were practicing gait training. So since that study came about, I think more and more research studies have focused on the idea of error augmentation and introducing variability in practice. And we've found some really nice results.
Yeah, it's very interesting. John, here's a question for you. Have you found a brace that helps with knee hyperextension in stroke patients? That was a question.
Could you repeat the second part of the question?
Yes. Have you found a brace that helps with knee hyperextension for stroke patients?
To a point, we often will use heel lifts to try to post them into a more flexed position for the knee hyperextension. If they are really hyperextending their knee a lot in this therapy, sometimes we will put a Swedish knee cage or some other knee brace on them. The goal is that we want them to be able to get these thousands of steps and do the therapy, but to protect their ligaments. So it may not look perfect, but we may put something on them to, along with the AFO, to protect the knee joint. And when you had asked about the alignment earlier as well, it's difficult to align these patients in terms of AFO tuning because they change so much. So one of the goals of the AFO is to allow them to do these therapies, but to have a little bit less therapist assistance, but also to be able to do it safely and to not get skin breakdown or to have a really nice, well-fitting AFO for them to do it. So when we get to the more chronic stages of stroke, then we might be able to look at the tuning and alignment with a more traditional plastic or polymer AFO.
Another one, have you performed this work with intervals of sensory motor orthotic use during treatment?
With intervals of what?
Sensory motor orthotic use. I'm not quite sure.
I'm not sure if that's, are we talking about functional electrical stimulation? I'm not.
Yeah, I wonder if that's what it is. If a person could ask, verify, maybe.
I don't think that we usually use functional electrical stimulation, walk gait or bionis for the high intensity.
You know, we have done that in the past. The problem is that oftentimes those devices aren't covered by insurance for our patients. So while it is a nice intervention and sometimes very beneficial, especially if a patient has cognitive impairments that's limiting their awareness of their impaired side, you know, obviously that stimulation can bring a little bit more awareness. But really, we don't tend to use those devices too much just because, like I said, insurance doesn't cover it. So we really want to get the patient comfortable with what they're going to be discharging with and practice our interventions with that device.
I know every patient's unique, but is there an average length of time that this treatment would last? The high intensity training?
So there are recommendations in terms of length of time for the inpatient setting. You know, we are really seeking to implement this intervention at least 4 times per week for the entire length of stay. On average, our patients stay for about 3 to 4 weeks. Obviously, you know, we don't stop the intervention once that time period is over. Like that question that you asked earlier on, we would want to continue high intensity gait training in the outpatient setting if the patient continues to have deficits to improve upon, which most of our stroke patients do. So really, we're more so looking at the frequency per week and making sure that we're achieving the appropriate intensity levels. And then in terms of the actual duration for how long this intervention is performed following the stroke, you know, that's variable depending on the patient.
And we've seen some patients improve even at the 1 year mark post-stroke from 1 year to 2 year. But I think with Caitlin and the therapist, we're really trying to capture that window of neuroplasticity after stroke between 2 weeks to 6 months where we can really make a huge difference. But we want to continue that as far as we can, even outside of that subacute phase.
Interesting. I'm an orthotist, so I like talking about bracing, and I just wondered, John, do you ever use some of the, now they have a lot of carbon fiber energy storage AFOs like later down the road after they've had some more treatment, or have you ever used those, or do you stay with all of the custom made devices?
No, we do use the carbon AFOs as well, but I would probably say for the acute and subacute, I may use that 10 to 15% of the time. And really, if it's a patient that they're just presenting with that toe drag or foot flat at initial contact, and if they don't have any knee instability in terms of flexion or hyperextension or pronal instability. So for for those kind of with a straight drop foot, they work great. And there are times where we have patients that have fluctuating volume or very poor insensate skin, where I've used carbon AFOs just to reduce the contact with them. But I would say for most times, with the amount of steps that the patients are getting in and the variability and the way that they're moving, if we have a custom wall fitting AFO, then there's less chance of skin breakdown, which is a big factor, and more acceptance of using it as well. And the last thing about that is with the plastic polymer custom AFOs, we can adjust those as the patient improves. So if they start with the solid, we could eventually trim it to flexible if we're just weak in dorsiflexors, where the carbon AFO is what it is when you start, and that's what the function is going to remain.
Well, thank you. I think that's it for our chat. I don't see any other questions. So yeah, thank you so much for the presentation.
Thank you for
Very
Thanks so much.
yeah.
I think we have some certificates for you. I'll just see if they come up on the screen.
Okay.
Whenever Marlo was getting that together.
Okay, thank you. Thank you so much. And thank you, Caitlin. Thank you, John and Rajiv for to be a moderator. We have another announcement to make before we finish this session. But we have seen that the people are getting in now, more people that we were expecting to be here before. But problem with us in Mexico is that we haven't changed the daylight saving time. So the official number was 10 Central Time. That's mostly for USA as well as Canada. And for Mexico, we really make the announcement that we should be here at 9. So as you can see now, people is getting in more and more now, which is confusing in this moment. But we really apologize for this misunderstanding to people that are attending now. But those who have registered, they will have the chance to really get the link, because you authorized to record this session.
Yes.
So they may have the access to see it again. So thank you so much. And let me then do this certificates, and we let Linda Laxo to do the announcement. So let me just to give you the, thank you. This, I'm sorry. This certificate of participation to Caitlin Deom to be as a speaker for this second international webinar, and as well as for John, John Freddrick. Thank you so much, both of you.
Thank you for
being part of these webinars. We really are very excited, to then that these 3 societies, Canada, USA, Mexico, are all together in this to promote these webinars in order to recruit people to attend the ISPO World Congress. That this time will be in November. But I let Linda to do the announcements then. And I just want to thank you, John and Linda, one more time, and Rajiv to be the moderator. So Linda.
Thank you, Marlo. And again, thank you, Caitlin and John, for joining us today, and everyone who attended. We just wanted to give you some updates about what's coming up as far as new educational opportunities. And first off is the American Academy of Orthotists and Prosthetists. Their virtual symposium will be happening May 4 to 7 coming up. And then next would be Orthotics Prosthetics Canada. The virtual presentations will happen August 19th and 20th. And again, Orthotics Prosthetics Canada. And then the American Orthotics and Prosthetics Association National Assembly will be September 9th to 12th. And then finally, the ISPO 18th World Congress will be a virtual edition again in November 1st to 4th. And then we'll be hopefully looking forward to our next ISPO World Congress in 2023 that will be live. And that's it for what's coming up. And I hope that you'll join us for our next session. next month. April 30th, we have the webinar coming up. Again, same time in occupational therapy and limb loss rehab. Thank you all so much for joining us today, and I'll pass it back over to Marlo.
Yes, the next webinars. Now this time will be okay, because as you can see here, this says 10 a.m. Central Time, so we'll be on time, at the same time as zone, as we are not now in this moment. And for those who are overseas or other countries, yes, the UTC is the most common time zone that is used. So this is the difference in time. So we have the Sean Swanson for the occupational therapy and limb loss rehabilitation. So this is going to be very excited topic, a webinar. That's for April 30th, that you can see here in this. And then the next one will be on treatment planning and fitting of cranial remodeling orthosis adjustments. So that will be by Tiffany Graham, that she will be on May 20th and the same time, 10 a.m. and this is our UTC. So this is the next that we have for webinars. So we hope to see everybody, and we're really sorry, but because the time change wasn't the same, so we are missing some people that wanted to attend these webinars. So other than that, I just want to say thank you, and we hope to see everybody, most of you, next webinar in April. Muchas gracias. Thank you so much.